Okay, this video is about the thoracic aortic arch. It started out, I just had a conversation with a medical student about the anatomy of the arch, and they said, oh, they know the ABCs, and I thought that was rather clever. So here's the aortic arch, the thoracic aorta in your chest. Here's the heart right here, the coronary arteries, and then ABCs means A for aorta, B for brachiocephalic artery. Brachial means to the arm. Cephalic means up to the brain. That's the right carotid artery. This would be the right subclavian. The C right here is for carotid because the left carotid artery typically comes off separately. As a matter of fact, it can sometimes come off the brachiocephalic. That's called the bovine arch. It used to be relevant when we used to do a lot of catheter arteriograms. I did about 500 cerebral arteriograms back in the old days. Okay, but then this is S. So A, B, C, S. ABCs. So carotid for left carotid, S for subclavian. All right, and then these yellow spots are atherosclerosis. This is Asian pattern of atherosclerosis, meaning that like Japanese 1960s when they're smoking a lot of cigarettes, that's a stimulant, vasoconstrictor, raising their pressure, increases their hematocrit, raises their blood pressure as well. And they were eating tons of sodium, like 12 to 14 grams a day. So that's hypertensive atherosclerosis, Asian atherosclerosis, a lot of intracranial atherosclerosis. Okay, here's Westerner atherosclerosis, most commonly, let's say, in the coronary arteries at bifurcations. Also rather commonly in the internal carotid artery, again at the bifurcation. This is common carotid artery bifurcation to external carotid to the face, internal carotid artery up to the brain. So you can also call this high-fat atherosclerosis is the Western pattern, and hypertension due to sodium and cigarettes is the so-called Asian pattern of atherosclerosis. Okay, so the most important thing to know about the thoracic aorta is the Windkessel effect. Everybody should know this. Doctors do not know this, okay, but everyone should know this. This is super important. Okay, the ascending thoracic aorta is like a second heart. When your regular heart contracts, the left ventricle, it pushes blood into the ascending thoracic aorta, which then stretches outward because it has elastic fibers. And then during diastole, which means cardiac relaxation, the ascending thoracic aorta will recoil inward, elastic recoil, and that propels the blood out to the rest of the body. And that's how you generate flow during diastole. Diastole means relaxation of the heart. So what happens to the typical American is they eat a high-fat diet with a lot of sodium. Sodium vasoconstricts the periphery, the small vessels beyond the aorta, and then you have to pump higher pressure to get the blood to where it needs to go. The purpose of blood pressure is to get blood flow to your brain. The hardest spot to get blood flow is the top of your brain because you have to go against gravity. That's the job of the heart, to get blood flow to the brain. The job of the liver is to get glucose to the brain. All right, so what this means is if a person's eating chronic high fat, makes the blood thick, increases blood viscosity, the heart has to pump harder to pump a milkshake up to the brain than to pump water up to the brain. It's thick because of the fat. And then if the system's all constricted, the vessels are narrowed because of the sodium, then you have to pump higher pressure to get it up. Typical American eats a high fat, high sodium diet, so their heart has to pump higher pressure. What that means is these elastic fibers in the ascending thoracic aorta, they get overstretched over time. So by the time the person starts losing them after 20 years of age, they can no longer regenerate the elastic fibers in the ascending thoracic aorta. And then they've trashed them quite often by the time they're about 40 or 50, and they're pretty much dramatically diminished, and they're not coming back. So they tend to get more and more systolic hypertension. They're not generating much diastolic flow. So you don't want to trash those fibers, because once you trash those fibers, in order to get adequate blood supply to the brain, because you can't generate much diastolic flow, you have to raise the systolic pressure. And you also have to be careful. You don't want to set arbitrarily the blood pressure must be below 120, because when you don't have much diastolic flow, you're going to need a higher systolic flow to get adequate blood supply to your brain. The most important thing is you get adequate blood supply to your brain. It's not what your numbers are when you check your blood pressure with a cuff, okay? And make sure you're checking your blood pressure with the right cuff. You know, if you're using a cuff that's too small, it's going to artificially increase your blood pressure, okay? I think that's happened to me. You know, with my big muscles here, if they put a small cuff on me, it artificially raises my blood pressure. You know, somebody was telling me I had hypertension, and I think it's because they had a small cuff on me. Once they went to a normal size cuff for me, like a medium cuff, my blood pressure was fine. It was normal. So that's another important point. And then other things happen during diastole, cardiac relaxation. When the heart is contracting, that's systole, then all the cardiac muscle is tight, so you can't get much flow into that muscle. So it's during diastole that blood will then go into the coronary arteries and perfuse the heart. When you look at blood pressure has a number on top, that is the systolic pressure, and it has a number on bottom. That is the diastolic pressure. Normally, let's say you got something like, 110 over 70. That would be a pretty good pressure. 110, the systolic number minus the diastolic, 70 would be about 40. That's called the pulse pressure, the difference between the systolic and the diastolic. And by the way, you see me talking about this stuff, and it might seem a little boring, but let me tell you, this is the main reason people die. The number one risk factor is atherosclerosis. So high-fat diet, high-sodium diet, and high blood pressure is the number one reason people get atherosclerosis and get strokes and become demented. So what I'm telling you is essential stuff to being healthy. It's super, super important. And I can also tell you, most doctors don't know what I'm talking about here. They don't know the Windkessel effect. They'll know blood pressure, of course. All right, so anyways, as you get older, if you've trashed all of your elastic fibers in your ascending thoracic aorta, you'll tend to get more and more hypertension and a wider and wider pulse pressure. So here is rather severe hypertension with a systolic of 200, diastolic of 100. The pulse pressure here would be 100. So a high pulse pressure is actually a bad thing. I'll show why in just a moment. It damages the arteries of the brain. Okay, so let's also talk about cholesterol. The higher your cholesterol, your total cholesterol, in particular your LDL cholesterol, it's a bridging molecule, meaning that it sticks red blood cells together. So red blood cells normally repel each other. They've got something called a zeta potential. And when you've got these bridging molecules, positively charged molecules that are big enough to overcome the zeta potential and hold red blood cells together, they're going to hold the red blood cells together. Those are called bridging molecules. So LDL cholesterol does that. That's why cholesterol is a risk factor for atherosclerosis. Chylomicrons will do it. IgM antibodies will do it. Fibrinogen, the fibrin, the clotting protein, will do it. Uric acid will do it. LPS and LTA, the bacterial endotoxins, will do it. Okay, so that's why you don't want leaky gut. You get those endotoxins, okay? This is why you don't want to be eating lots of meat. You don't want to be eating lots of fructose, for example. High fructose corn syrup, in particular, is what I meant. Being excessively stressed out will increase fibrinogen. Having active infections, acute phase reactants, stress, sleep deprivation will do that. High-fat diets, especially, high saturated fat. Acute infections, IgM will do it. Okay, when something sticks the molecules together, the red blood cells together, normally red blood cells about 7 microns, capillaries about 5 microns, so the RBC has to fold back on itself to form to pass through the capillary. When it's all stuck together like a giant submarine sandwich, then it's harder to push that blood through the capillary, so blood pressure has to go up. Again, the concept of normally you're pushing water. When you eat a high-fat meal, you start pushing a milkshake through there, pressure has to go up. And if the vessels are normally this big and then you constrict them down because of sodium, pressure has to go up more. The more your pressure is elevated, the sooner you're going to destroy the elastic fibers in your ascending thoracic aorta, and your hypertension is going to become more irreversible. And that's why I think all this people recommending high-fat diets to the vegetarian, vegan population, I think it's stupid. I think all the fats are stupid and they're bad for you. And I'm just telling you the truth. No one's going to tell you that. There's too much money in selling olive oil, selling omega-3s, selling nuts, all this crap and all this seeds and stuff. I think it's a bad idea. All this fat, it's going to make your blood thicker. It's going to give you pressure problems down the road. They'll say, oh, well, omega-3s, lower triglycerides, isn't that favorable? They're a mild anticoagulant. They're still pushing you towards being fat. They still cause insulin resistance. Insulin makes your blood hypercoagulable for multiple reasons, causes tons of other problems. So I don't think you're going to win with that. I would recommend staying away from all the high-fat foods. Okay, here's a picture of your coronary arteries. The right coronary comes off on this side, left coronary artery comes off on this side. Left main bifurcates into the circumflex and into the LAD, left anterior descending. This is the one they call the widowmaker. So the typical thing they'll tell you when you go for a cardiac stress test or something is, oh, you got a narrowing here, or maybe cardiac cath. You got a narrowing in your left main, that's the widowmaker. You need surgery, or you need a stent if they think they can stent it. The other point I want to make is, the William Roberts paper, 2,000 consecutive autopsies for people who died of cardiac causes, especially, myocardial infarction or arrhythmias, especially thought due to ischemia, is that you can only stent relatively proximal in the circumflex LAD where there is a fixed stenosis. Okay, what I'm trying to say is as you get out far, far distal, the vessels start getting too small, and you can't fix these intramyocardial branches, these intramuscular branches like here and here and here, and you get a lot of atherosclerosis in them. And atherosclerosis, as the William Roberts papers show, they tend to be diffuse, about the same severity all over the place throughout the coronary tree, such that there's no such thing as single vessel disease. He says that's a myth. And what I'm saying is there's no way you could treat all that stuff other than a medication or fixing your diet. And we know that medications don't tend to work well and they have a lot of side effects. So either you fix it with your diet or you're stupid, okay? That's what it comes down to. There's no magic or mystery about it. And one other point I wanted to make about this is this fills during diastole. During systole, when the heart muscle's contracted, you can't push blood you can't effectively push blood into these intramyocardial arteries. So you can only fill them during diastole. So once you trash your elastic fibers in your ascending thoracic aorta, it's harder to perfuse your coronaries. And you see how you can develop a vicious cycle. You're not getting enough blood in your coronary arteries, so it's going to want to pump harder, but then it's having to be contracted longer, contracted more intensely, and it trashes the elastic fibers more. You see how it cycles into a worse and worse situation, a vicious cycle. Okay, this is just making the point. This is why women live longer. Women have menstruation every month when they're premenopausal, which lowers their hematocrit, and that lowers their blood thickness, their blood viscosity. Over 99% of your red blood cells are red blood cells compared to white blood cells. So whatever happens to your hematocrit has a big effect on your blood viscosity, your blood thickness. So that therapeutic phlebotomy of menstruating every month lowers a woman's hematocrit. And so she has lower blood pressure. In addition, what happens too, when red blood cells first come out of the bone marrow, they're more flexible, deformable, so it's more easy for them to bend back on themselves as they pass through a capillary. The older red blood cells get, the more glycated they get, the stiffer they get, and they are less able to deform readily and deliver oxygen as effectively. And because of that, pressure has to go higher because they can't deform as well to more readily pass through the capillaries. Because again, the red blood cell is about 7 microns in diameter. Capillary is only about 5 microns, so it needs that deformability. Okay, so I was making the point again that with high blood pressure and the Windkessel effect, once you lose this Windkessel effect, your systolic pressure goes up, you can't generate as much diastolic, and so that blood comes up towards the brain, in the neck at a higher pressure and hitting the brain arteries at a higher pressure, and it can damage them. Because what you really want is a Goldilocks effect, the pressure just right. If your pressure is too low, you don't get enough blood to your brain, that can make you demented and stupid, okay? If your pressure is too high, it's bam, 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 bam. It keeps hitting the small vessel bifurcations in your brain too hard, and they compensatorily lay down collagen, like fibrosis, and they become scarred off to some extent and less effective at delivering oxygen, okay? So what I'm trying to say is hypertension is super important, and I'm explaining to you why it happens and what you can do about preventing it. And what I'm trying to say is all the medical books are a joke. They're all stupid. They all tell you, well, most hypertension is essential hypertension, meaning that we don't know the cause. This can also be referred to as idiopathic. You know that. The doctor's an idiot and the patient's pathetic. So they'll tell you that's about 95% of hypertension, which is absolutely stupid. And I thought about it. The teaching method for medical school is what I would call learned helplessness. We don't know what causes it. Nobody does. Just give them this pill. Hope for the best. Maybe we could slow it down. And then based on some fake studies that exaggerate the benefit of the blood pressure pills, I think they're very dangerous because you overtreat that hypertension, you don't get enough blood flow to your brain, and you miss that opportunity of fixing the diet and protecting these elastic fibers. So, okay, we'll continue on here. I'll show you more of what this is all about. Okay, so the blood comes up into the carotid artery in the neck, and it will hit the bifurcation. So blood comes up in the common carotid artery, hits the median divider of tissue between the external carotid, that's the artery that goes to the face, internal carotid artery goes up to the brain. When it hits this median divider here, it bounces off of it with turbulent flow. That's chaotic flow. And that includes some retrograde currents. Retrograde currents are called eddy currents. The endothelium is the name of the arterial lining cells, and they've got little hair-like sensors on their glycocalyx that sense the flow. When there's an abnormally large amount of turbulent flow or an abnormally large amount of retrograde flow, that's confusing to the endothelium, and it starts to shed its antithrombotic glycocalyx, sugar coating of glycoproteins, and it starts to express prothrombotic molecules on its cell surface, like VCAM, vascular cell adhesion molecule, and you'll form clots. And you'll typically form them right here on the far wall. I look at CT angiograms all the time, okay, and I can tell you this is where it happens. Everybody knows this who studies this. You'll start forming a clot here. And by the way, atherosclerosis is a blood clot. You need to know that. Until you know that, you won't ever be able to make any sense out of atherosclerosis. It's a blood clot. Pathologists figure it out. They look at it under a microscope. They go, it's a blood clot. I can tell you, looking at a CT angiogram, I've looked at many thousands of them. It looks like a blood clot because it is a blood clot. All right, so anyways, that's where it forms. You end up with a steady state between formation and dissolution. And as a person gets older, more fragile, and has more hypercoagulability, clotting risk factors, it'll eventually start getting bigger, and they'll also start tossing little pieces of this carotid atherosclerotic plaque up to the brain, having these small little silent strokes. That's one of the mechanisms for that happening. Okay, and then here's what I meant with hypertension. You're between a rock and a hard place. If your pressure's too high, you'll sometimes get little microbleeds at the level of the basal ganglia. This is called the basal ganglia level. Here's the internal carotid artery coming up to the brain. It bifurcates. There's an anterior cerebral artery, which I don't have drawn on here because it would make the picture too complex. Here's a middle cerebral artery right here. These are the lenticular striate arteries that go up into the basal ganglia. These is a continuation of the MCA. We would call this the M1 MCA, and then we call this the M2. Well, actually, I would have another little, I'd have it move a little more. I'm not going to get into all the details of it. Let's just call this the convexity middle cerebral artery branches. All right. So what I'm saying is, if your pressure is too high, you run the risk of little microbleeds in this area and what are called hypertensive lacunar infarctions. You can shear off the base of these arteries, have little bleeds. On the other hand, if your pressure is too low, you can't get blood up to the top of the brain. That's the hardest spot to get going against gravity. And you don't have a lot of good collateral supply in this area. That's why I drew a skull and crossbone. These are the cerebral ventricles, contain cerebral spinal fluid. And right here, this is called the deep white matter, because these are the ventricles. It's called the periventricular white matter. Its official name is corona radiata. It looks like a crown. Up here it's called the centrum semiovalia, but you can also call it the periventricular white matter. That's where you get sound strokes. Most people over 60 in America have at least one of them. All right, so if you don't got enough pressure in your blood, you can't perfuse this area adequately. If your pressure is too high, you damage these arteries and you can bleed into your brain. Usually those will be microbleeds. Microbleeds are common. Macrobleeds are uncommon. So what we really want is the Goldilocks effect. You want just enough pressure to perfuse your brain correctly, and you don't want so much that you have the bleeding. You don't want so little that you don't get enough blood to your brain. And what gives you this? Low-fat, low-sodium vegan diet. Okay, that's why it's a smart thing to do. And that's why I'm a big fan of this diet, because it works, it makes sense, it's logically consistent with itself. And when you understand that, all this stuff just makes sense. It's no longer some mystery. It's no longer memorizing something. It's no longer somebody's opinion. It's a coherent, rational approach to nutrition and understanding the physiology, the pathophysiology. Okay, and also that's why when you hear me talk, I'll tell you McDougall's the best one, and I think I'm like second best or right up there, because I'm giving you the coherent rationale. I'm not just telling you, take my opinion. You could figure this all out for yourself. You could read all these papers for yourself, but you'll see that it makes sense. You eat starch, you eat low fat. All of this stuff makes sense. Now, these are cerebral microbleeds, these small little black dots. This is what's called a susceptibility weighted image, whereby they don't have all the refocusing pulses such that it's more sensitive to distortion of the magnetic field. This isn't an MRI. MRI is magnetic resonance imaging. The patient sits in a giant magnet, like 1.5 Tesla, like 1,500 times the Earth's main magnetic field. And something in there that distorts the magnetic field, like a little bit of heme from blood with iron in it, causes this appearance on susceptibility weighted imaging. Okay, so a bunch of central microbleeds in the basal ganglia. That's classic for hypertension. You see that every day. All right. When they're out in the periphery, I think they're still primarily due to hypertension, but there's a few other things that can do this. We don't need to get into the whole differential diagnosis, but I can just tell you, I see them tons of times out in the periphery in young people too. All right, now here's a macro bleed, a big bleed. We'll often call this an IPH, intraparenchymal hemorrhage. These little tiny white spots are just calcifications in the basal ganglia, and that's common. We even consider that normal, but I don't really think it is. I think it's atherosclerosis as well. But this big honking bleed, this is a big hemorrhage, acute hemorrhage into the basal ganglia from hypertension. And this is a much more serious thing because it's so large. These are small micro hemorrhages. We call these CMB, cerebral microbleeds. But anyways, what I'm trying to say is this is hypertension. This is what hypertension does to brains, okay? Especially this. This is rare. I only see this a few times a year. This I'll see every day, okay? And then what I was talking about too, when you have the high pulse pressure, you're damaging the arterial wall. So here's a normal capillary. Here's the capillary basement membrane, this yellow line. The green cells here are the vascular smooth muscle around the capillary. These spindle-shaped cells inside the capillary are the endothelial cells. This is the entry site of the capillary. These are the red blood cells that bend back on themselves again because they're a little bit bigger than the capillary as they flow through it out the other end. The blue circles are the oxygen being delivered that has to pass out of the red blood cell from its hemoglobin through the capillary basement membrane, across the vascular smooth muscles, and then to the tissue cell, the neuron, the brain cell. Okay, so now chronic diabetes causes thickening of the capillary basement membrane. It gets glycated and damaged in other ways, and you also get hypertrophy of the vascular smooth muscles, especially from hypertension. But the net result here is you get laying down of collagen, fibrosis, making the wall of the capillary thicker. All of these things increase the difficulty of delivering oxygen from these red blood cells to the neuron. Okay, so this is going to make it harder to meet, the oxygen glucose demand, to meet the metabolic rate. It's going to make it harder to deliver that oxygen, okay? And the high blood pressure, pop, 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 constantly hitting these vessels hard is going to damage them over time, and they're going to compensatorily hypertrophy the muscles and also lay down more collagen, more fibrosis tissue in the wall of these arteries, which are going to make it more difficult to deliver oxygen to the tissue. So again, you get yourself in a vicious cycle when you're screwing up. That's why I think it's important to try not to screw up. When I say screw up, what I mean when you eat the wrong foods. So it's like you're basically poisoning yourself. Why would you want to do that? That's not smart to do. You want to keep everything working as best you can. All right, so let me just show you what a normal brain looks like. Here's a normal brain. The ventricles are small, and this is what we call a tight brain or a young brain, because the sulci are relatively small. Sulci are the little infoldings of the brain tissue, okay? And this is exactly how a normal brain should look. Okay, this is called a flare sequence. Flares are a very popular sequence. It's really like a T2 sequence with CSF suppression of signal. And essentially the joke is this is the desert islands sequence for a neuroradiologist. If you were stranded on a desert island, you could only have one sequence, you would want flare. Because it's like a T2, but it suppresses the CSF signal, so it's perfect. All right, so here is a typical, let's say, like this would be like a bad brain for an 85-year-old. But it'd be very common for an 85-year-old. Now, don't get me wrong. I see some 85-year-olds that look almost like this, except the vents are a little bit bigger and the sulci are a little bit bigger. But they're pretty darn close to this. I've seen some 85-year-olds with no silent strokes. All right, but more often than not, I see them a little, not quite as bad as this. But this would be pretty common, let's say, an 85-year-old, 90-year-old. At least they made it to that age. But what I'm trying to tell you is you don't want these things. These are all silent strokes. Sometimes they're not necessarily silent. Quite often they are. They're silent in the sense that the patient just is weaker, clumsier, a little mentally slow, but they don't have a frank neurologic deficit. They can move both of their extremities, upper extremities and lower extremities. But this is very typical in these old cognitive decline patients, okay? But they don't have to have these. I've seen tons and tons of demented, cognitively declined patients that don't have any silent strokes. And there's a reason for that. They've got apoptosis. But I'm just saying this is the end result of chronic overtreated hypertension, chronic hypertension in general. Hypertension is the main risk factor for these periventricular flare hyperintensities. Just means white spots, okay? We call them hyperintensities. That means hyperintense signal. Bright signal is hyperintense. And again, none of this stuff starts happening until they trash their ascending thoracic aorta, trash those fibers. And so again, this is why I'm telling you, I think all this high-fat diet, this high-fat veganism is for chumps, okay? I've had people tell me, they stayed on those high-fat foods, all those nuts and seeds and omegas, and they couldn't get their hypertension turned around until they went off that stuff. Okay, here's your hippocampus, very sensitive to atherosclerosis, very sensitive to hypoxia, underperfusion, and it's your main memory center. So when this gets damaged, and like I said, it's very sensitive, it's early to go, the person starts becoming demented. So you don't want that. And it's very sensitive to problems with diabetes as well. So the most important part of your brain is also about one of the most fragile parts of your brain. And we spoke about this before, the whole Jack Delatorre theory of dementia, also called the vascular hypothesis of dementia. I call it the mouse equivalent theory of dementia. So Jack Delatorre, he wrote a really great book called Alzheimer's Turning Point. He would die off the carotid artery in a mouse, and then middle-aged and older mice, 2 months later, they'd be demented. He's expecting a big stroke on the same side. He tied off the carotid in the neck, and it turns out they just had a shrunken brain on the same side. So that's consistent with apoptosis. And he experimented with tying off both carotids, tying off the vertebral arteries as well, tying off arteries in the brain, the MCA. The bottom line is when you deprive a brain cell if you completely deprive it of oxygen, it dies right away. That's called necrosis. The plasma membrane lysis, big mess. You can see it on an MRI. On the other hand, if you just deplete its oxygen glucose supply by occluding this artery right here, it still gets some, so it doesn't die immediately. It just gradually dies over the course of the next days to months, and the mouse becomes demented. And those cells are reabsorbed. They're recycled by the microglia, the immune system, if you will. And because of that, you can't see anything in MRI. You can't see anything in autopsy even, other than there's less than expected number of cells. Okay, and then lots of things will do that. Atrial fibrillation, You decrease the brain perfusion because you're losing that atrial filling, let's say 20% or something, or 25%, that could go up to the brain. Congestive heart failure, you can't pump enough to get enough blood supply up to the brain. Remember, that's the heart's job, to get blood to the top of the brain. So if you can't pump well, you can't do it. AFib, you don't fill the heart well, can't do it. Obstructive sleep apnea just means you're not breathing enough at night and you get hypoxic up there in your brain. Diabetes, they'll often give themselves too much insulin and they'll drop their sugar at night, and hypoglycemia can also cause you to lose brain cells. You overtreat hypertension. You try to get the pressure too low. Really low pressure is more dangerous typically than really high pressure, and that can stroke the patient and give them the little silent strokes commonly. You undertreat the hypertension chronically, and you damage the vessels from the high pressure. That's why the smart thing is get it down as much as you can. It's a smart thing I would do. Minimize dietary fat, minimize dietary sodium, avoid excessive stress, get your sleep, avoid caffeine. Okay, aortic stenosis, aortic regurg will do it. Post-cabbage hypotension, they'll run pressures really low to prevent bleeding out at the anastomoses after open heart surgery at the bypass grafts. Okay, and I talked about other things in my other lectures. I won't go into this anymore. Okay, here's a typical brain I see on a demented patient. This is what they usually look like. The brain's just shrunken. All this cerebrospinal fluid means that the brain is shrunken and falling back away from the frontal bone up here. This is a loose brain, and compared to that young patient, I call it a tight brain, meaning it's loose in the sense that there's big cerebrospinal fluid, big sulci with lots of cerebrospinal fluid going in there. These vents are still pretty normal sized. Up higher, they might get a little bit bigger, but they're certainly bigger than they were in the other patient. So this is a typical brain I see of a dementia patient. It's atrophic. There's no big stroke. It's just a shrunken atrophic brain. And this is what chronic atherosclerosis, chronic hypertension will do this, chronic overtreated hypertension will do this, diabetes, all the vascular risk factors, typical Western demented brain. I think that's my last slide. Let me see. Oh, no, I got a little more. Okay, this is just the stuff we talked about. If you feed them sat-fat, Peter Quo's 1950s research studies, he's a cardiologist from Philadelphia, took his cardiac angina patients, checked their blood lipids every 30 minutes, and at peak lipemia, they also had peak angina. And he tried it then in the 1960s. And then also Ray Rosenman and Meyer Friedman did these experiments, the ophthalmologists. They tried it with unsaturated fat, the PUFAs, omega-6 cooking oils, and it was even worse. More prolonged blood sludging, hyperlipidemia with causing tissue ischemia. And they also showed that in the eyes with an 80-fold power microscope. All right, the other things to know about the aorta, we're not going to go into these too much detail. These things are relatively rarely of significance. You can get aneurysms. Most commonly, you'll get diffuse ectasia from hypertension. You can get aneurysms. It's not that often they need to go to the OR. Sometimes, but not that big a deal. Everybody has problems with hypertension. I can tell you, if you just tell me, American patient, 60 years of age, you don't have to even give me a chart. It is a safe assumption that patient has hypertension and diabetes. I don't even have to look in the chart. I guarantee they got prediabetes and they probably have hypertension. I don't even need to look in the chart. I always assume that. Always. The patient is diabetic and hypertension. That's how common it is. Okay, and if you tell me that patient is demented, I won't even look at the scan. I will expect to see at least one cataract surgery, probably both, and I'll expect them to have poor dentition, poor teeth, because they almost always do. All right, what else? Dissection, they're rare. They can be a big deal. The Stanford classification is good for that. These are the kind of things I think about when I'm on call, but I hardly ever see this stuff. PUDAs, penetrating ulcer or descending thoracic aorta. Yeah, it's really rare, but it can be a big deal. Strokes from atherosclerotic plaque, with the retrograde flow going up into the brain. Yeah, it can happen, but it's relatively uncommon. We don't look for it that much. We certainly look at the arch on a CTA after a stroke, but that's not like the main point. The main point was Windkessel effect. Get that Windkessel effect. Avoid the dietary, excess dietary fat and dietary sodium, and manage your stress and avoid caffeine. That's kind of the point of all this. But understanding that Windkessel effect, I thought that was real useful, and I thought that was kind of a nice little mnemonic at the beginning of the ABCs. Aorta, brachiocephalic, carotid, meaning left carotid, and then S for subclavian. So anyways, hope